So the first one is fibrous, which is the thick tissue outside of it, and the serous layer, which is next to the touching the heart. And then that one is divided into parietal and visceral. The main function for pericardium is to anchor and protect the heart and the vessel inside the pericardium, because as you know, the heart sits in the chest cavity next to the lungs and above the diaphragm, right? So it needs protection from the pressure changes in the thoracic cavity. And normally there is a pericardial fluid which is about 15 mil, no more than 50 mil in between these layers, as a lubricant for when the heart moves around. And it's innervated by the phrenic nerve. And that's what it looks like. So the heart will sit inside the pericardium, and below this is the diaphragm. And in between these layers, there's usually a small amount of fluid in between. There are many diseases that can affect the pericardium, and one of the more common one is pericarditis, especially now with the COVID-19 era. We find more and more of these, especially in patient with COVID, or recently with some patient who has reaction to the vaccine. So pericarditis, as the name suggests, is an inflammation of pericardium. And once that happens, it can cause chest pain and ECG changes. And these changes can mimic ST elevation MI. However, the pain is not angina pain like we learned before. The pain is pleuritic, meaning that it changes on inspiration. So it's usually sharp and worse with inspiration. And in some patients, it can be worse on lying down and better when leaning forward. And this is the typical pericardial pain. The reason for the pain to be when it's worse on lying down is because when the patient lies down, the pericardium is touching the heart directly. And when that happens, it is painful, right? So when they lean forward, sitting upright, there's a little distance between the pericardium and the heart. So the pain is subsided a little bit. And there are multiple causes. So I mentioned just now post infection or myocarditis or vaccine, right? But sometimes it can happen on its own, so that's idiopathic. And sometimes it's due to medication or tuberculosis in Thailand. Other than that, sometimes we don't know the cause, or like it can be related to other autoimmune disease like rheumatoid arthritis. Yeah, and if in elderly patient with cancer treatment, sometimes we can find it after radiotherapy or chemotherapy as well. So because it's a thin layer, it may not tell us anything much. Echo sometimes can be normal as well. And because the pain can mimic ST elevation MI, so we need to look at it carefully. Sometimes we end up doing coronary angiogram just to rule out myocardial infarction as well. The treatment depends on the severity of the disease. If it happened in a young person and the symptom is not very much, then we can sometimes observe it. But usually we can give them high dose ibuprofen or aspirin, and sometimes colchicine as well to reduce inflammation. These treatment are just for reducing inflammation. It doesn't really treat the ongoing causes. So let's say if they have pericarditis due to COVID, right? We just have to support the disease by reducing inflammation because we don't have medication for COVID. Or if they have pericarditis from radiotherapy, we may be able to stop radiotherapy and do other things. It's a complex pathophysiology, but fortunately, you don't need to learn all of this. It's just so that you know there's a lot of things happening causing inflammation of the pericardium. So for clinical diagnosis, right, there's a few definition, but for most of you and chronic, so for acute pericarditis, there should be at least 2 out of 4 of the following criteria. So the first one would be pericarditic pain or pericardial rubs, which is when you listen to the heart using a stethoscope and you can hear a rubbing sound, sometimes described as walking on the snow. Third is widespread ST elevation or PR depression on EKG. And lastly, pericardial effusion, which should be new or worsening, as in getting larger. Other than that, there may be supporting findings like CRP or ESR, inflammatory markers increase, and or if we use CT or MRI, sometimes we can see it as well. So 2 out of 4 symptoms. And if it's, so that's for acute. For chronic, it has to have happened for longer than 3 months. These are all the causes that we know, but yeah, we're not going to learn and memorize all of it. But generally, infectious cause is the commonest one. So viral and bacterial, fungal and parasitic is quite rare. Other than that is autoimmune and neoplastic that can be found, but again, not very common and very difficult to detect. So these are the ST elevation MI that we learned before, but this time there's ST elevation everywhere, right? For STEMI ST elevation MI, the ST elevation segment should be located in the area where there's MI going on. But because pericardium surrounded the whole heart, so we actually find that there's a ST elevation ST elevation in all the leads. So when that happens, it's most likely not an MI, but it's an pericarditis instead. Because you cannot have an MI in every wall, right? Because the patient would die by then. The other thing that we can find is PR depression, which is quite specific to pericarditis. So we look at the PR and it's depressed down lower than it should be. So if you find 2 of these, then most likely pericarditis and not ST elevation MI. So now those are the introduction to the disease. For this lecture, because it's an echo, right, we're gonna focus on echoes. So what can we find in acute pericarditis? I mentioned it can be normal finding at all because we may not find anything, but usually we should be able to find things like water, so pericardial fluid around the heart, or sometimes the pericardial layer can be thickened, especially in chronic pericarditis. If we find wall motion abnormality as well, then it could be myopericarditis, like in COVID or something. So pericardial effusion, similar to pericarditis, there are many causes, so I'll skip that part. But what we can see, because fluid is, it should be dark, right? Because it's water, so ultrasound should be able to pass through just fine. So it should be dark space, and we can use echo to see that. So if it's small, we consider that less than 1 centimeter. If it's moderate size, it's 1 to 2, and then if it's large, and it's over 2 centimeter. It can be asymptomatic, or it can, if it's large enough, it can cause dyspnea or fatigue as well. But if it's too large, it can cause cardiac tamponade, which we'll cover next. Most of the time, it can be normal, but if it's large enough, then we should consider things like if it's malignancy causing this problem, or if you go on to CVT next year. Sorry, if you go to theater next year, operating room, sometimes we can see it after the operation. And on chest X-ray, we can see that the heart gets larger, and this is because it's enlarged due to accumulation of fluid inside the pericardial space. So when it's large enough, the fluid can compress on the heart, causing cardiac tamponade, which just means that it's compressing onto the heart. And it's usually start from the right side. So because the right side of the heart is very thin, whereas the left ventricle is thick due to the muscle, right? So once the pressure builds up, it presses on the thinner side first. So it presses on the RV first. And by pressing on the RV functions to pump the heart into the lung and to the left side, right? If it's being compressed, it cannot do those functions. So even though the left side is functioning well, there's no blood for it to pump because the RV is not pumping the blood to the left side. So the patient will develop into shock and can cause cardiac arrest. On examination, we can find what we call Beck's triad. So the patient will have hypotension and elevated jugular venous pressure, and the heart sound will be distant and muffled because the fluid is blocking the sound of the heart, and hypotension due to the shock due to the compression. Another thing that we can find is pulsus paradoxus, which is when we measure the blood pressure and it's drop by more than 10 when the patient take a deep breath in. Hang on, sorry. The diagram will look like this first. So that's normal. Normally the pressure inside the heart can expand when the blood fill, but once the fluid become too large, it presses on the heart, and then it compress the RV and also compressing onto the LV. I'll show you the echo next. Causes of cardiac tamponade is the same cause as pericardial effusion. So things like pericarditis and trauma and malignancy. Another thing that we can find on EKG is because the fluid is surrounding the heart, right? So the electrical current can be reduced because it has to travel through the water into the chest lead. So it will look like the QRS complex looks smaller than it should be. And then another thing that we can find is called electrical alternant. So if you look at it, the R wave here, it looks like it's swinging, right? Because it's inside the heart, and you'll see this next, because the heart is swinging inside the pericardium. So the QRS complex looks up and down like that. So this is the echo of the patient with large pericardial fluid. Normally, if we do this on site, I'll ask you to point out, but I'll just point it out to you. So this is the RV up here, and that's the LV. And these are the water outside the heart, so within the pericardium. From just looking with eye test, it looks about 3 centimeter wide. So that's a massive pericardial effusion, as well as there's probably a little bit of protein inside there as well. Now we go from, so that's parasternal, sorry. That's parasternal view, long axis, right? Now we're looking at, I think it's 4 chamber, but it's due to because loss of pericardial effusion, the heart is swinging within the pericardium. This is the pericardium. It looks a bit thick. And all this dark space is pericardial fluid surrounding the heart. And you can see the heart is moving around inside there, as well as the RV is being compressed. This is the RV, this is the RA, LA, and LV. If you keep looking at the RV, you can see that it's being compressed there by the pressure from the pericardium. See, there's no RV. So this patient has cardiac tamponade right now. And as you can see, the heart is swinging. So the EKG will look like that because it's measuring the electrical current from the heart onto the EKG leads on the chest, right? So if the heart is swinging, it will like it's not move. So it will look like it's moving, basically. But to consider it tamponade, we need to look at when and where the RV collapse as well. So the RV should collapse in diastole and right or left atrium collapse during systole. This is because during the diastole, that's when the heart filled up, right? So that's when the pressure is highest in the RV. If the pressure in the RV is at its highest and the RV is still able to be collapsed by the pericardium fluid, then it means that pericardial fluid is just too much. So now it's at the tamponade level now. Like that. So if you measure it, so yeah, 3 centimeter, 3.6. So massive pericardial effusion. Yeah, so we call that a swinging heart sign. That's a 4-chamber view. So the probe will be sitting on the patient's apex beat, right? As you learn. So the probe will sit on the chest, and there's a gap between the chest wall and the heart for about 2 to 3 centimeters full of fluid here. And once there's a swinging heart sign, it's most likely that the patient has tamponade already. So we need to do pericardial centesis to remove the fluid. We can also look at the RV collapse, whether from using M mode as well. So the RV is up here. Sorry, the EKG is blocked, right? So that's systole period because there's a QRS there. And then the diastole is right before that. So if there's RV collapse there, we can see it here as well. Or we can use, we can pause the image and look at it. If there's an RV early diastolic collapse, then it's most likely tamponade as well. But you need to look at the EKG while doing it. For RA, you need to use 4-chamber view. And again, you should sync it to EKG. Sometimes if you don't have EKG, you can look at the mitral valve opening and closing. So it will open during diastole, right? But to be the most accurate, you need to use EKG to sync it. And the RA wall can be collapsed like that, bulge in. And that will happen during the late diastole to early systole, the opposite of RV, because they're feeling in a different phase of the heart. Another thing that we can look at is mitral valve inflow on top of how it moves according to the respiration. So we call that respirophasic changes. We will use PW on top of mitral valve, and then we speed up the time and ask the patient take a deep breath in and out. And when we mark the location of the E wave, hang on. Hello. ครับโอเคครับได้ครับ Sorry. So we mark the E wave of the Doppler, and then we mark it again where it's highest. In normal person, it should not move more than 25%, but here I calculated already. So up here is 40, down here is about maybe 20-ish. So that's 43 variation between these 2 points, and that's within the criteria of cardiac tamponade. There will be a diagram for you later, I think. Hang on. Yeah. Yes, this one. So if we go back to this, we'll see that respiratory variation in mitral is over 25. Just now it was 43, right? And we can do the same on tricuspid as well, but I generally suggest do it on mitral valve because RV move quite a lot and can be less accurate than LV. So we do that on the mitral valve. And the next thing that we can find is plethora of IVC, meaning that the IVC is dilated and not collapsed related to the respiration. So when the IVCs, normal person IVC is usually 1 centimeter or less, right? And it will collapse related to the respiratory phase of when you breathe in and out, because the pressure in the the pressure in the thoracic chamber changes. But when the pressure is too high, it doesn't move according to the respiration. So for this patient, we mark it here at 1.8 centimeter and 2.16 centimeter. It barely changes and is fully dilated. So that's called IVC plethora as well, meaning that the pressure within the right atrium is very high because the IVC is drained into the right atrium. So all of these findings suggest that the pressure in there is high and that pressure changes to vary too greatly, and that would suggest that the patient has cardiac tamponade. The treatment, as I mentioned, is pericardial synthesis, which is the removal of excess pericardial fluid around the heart using needles or drainage. And we can do it from two sides of the heart. So subxiphoid, which is where right below the sternal bones on your chest, and the apical approach, which is where you do your full chamber view. If it's difficult, we can do it under fluoroscopy. But most of the time when it's tamponade, we don't have time to do that. So we need to use echo guide and do it right away. And if the tamponade is happening and the fluid is usually bigger than 2 centimeters, so it's usually safe enough to do. But we can't do it if we think that it's due to aortic dissection and it's bleeding inside there, or if the patient has, coagulopathy means they have clotting problem, so they may well bleed too much if we do it. Complication that is possible is pneumothorax. We can puncture the lungs from going in a different direction or going too deep, or liver puncture sometimes. Or if we go too deep, the needle can hit the heart and cause VT or VF or bleeding. Pericardial window, we only do it in using CVT surgeons when they have chronic pericarditis or something like that. This is what it looks like. So that's the subxiphoid approach. And if we go by apical approach, we'll puncture the needle from over here. So we mark the area using the ultrasound probe, the echo probe, and then we insert a needle to where there is the most fluid, therefore the safest area to approach. And then we stick a needle in and we drain the fluid out. So that's subxiphoid. Parasternal, I don't recommend, it's too difficult, and the space there is not very much, and then you can puncture the heart easily. So it's subxiphoid and apical where we do it. Generally, apical is easier than subxiphoid because subxiphoid is near the liver, and if the liver is big, you can puncture the liver as well, causing bleeding. Any question on the pericardial fluid on tamponade. Because the next one will be constrictive pericarditis, and this one is even harder because of the pathophysiology and stuff. No? Okay, so constrictive pericarditis, it follows from pericarditis. If the person has chronic pericarditis, or like it keeps happening on and off, the pericardium becomes thickened due to the scar that it keeps happening to them. And when pericardium becomes thickened, it cannot move very well, and it becomes like a cage surrounding the heart. And once it's thick enough, the pressure inside the heart, inside the pericardium, and outside the pericardium in the chest doesn't transmit very well, and it can cause problem from there on. So again, anything that can cause pericarditis can cause constrictive pericarditis, especially those that keeps coming back, like cancer or TB or radiation. And when the pericardium becomes so thickened, the pressure cannot be transmitted, and it can surround the heart, and the heart cannot expand very well from there. So the symptoms would be more of a right-sided heart failure type, so dyspnea and fatigue, and sometimes they have limbs swelling, and in cases it can cause distended abdomen due to congested liver, so hepatomegaly and ascites. Sign that we can find is Kussmaul sign. So as the patient take a deep breath in, jugular venous pressure increases. In a normal person, it should decrease. And yes, pausus paradoxus, again, we can find in some cases if there's still loss of fluid left in effusive constrictive type. So I try to summarize the problem caused by it, but it can still be a little bit complicated. This is like the simplest way to think of. So stiff pericardium trap the heart inside and cause the increase in diastolic pressure, because normally the heart can expand, and due to the pericardium can expand, right? But because it's thickened, it cannot expand very well. The pressure equalizes in all the chamber. And because of this, when the right heart fill, it cannot expand outward, so it presses on the left ventricle instead, causing it to bulge into the left side. This is called the ventricular interdependence, and therefore reducing the LV and diastolic volume, and therefore reduce the cardiac volume as well, cardiac output, sorry. And this is worse when there's inspiration, when more blood is filled into the right side. So this is what it looks like. So when you inspire in, the right side of the heart is filled up, and it presses onto the left side. And as you expire, the left side pushes back into the right side. This normally happens very little in a normal person because the heart can expand outward, right? But because in constricted pericarditis, the heart is constricted, like the name suggests, within the thickened pericardium. So it has to move in between each other only. So we can see the septum swinging back and forth, which I will show you on echo. Causes will skip that part we already mentioned. So when the septal move in between them, back and forth, we call that septal bouncing. So it bounces back between right and left side. We should find pericardial thickening this time because it's chronic now and it's constrictive. Whereas for acute pericarditis, we may not be able to see this. And then respiratory variation between them, similar to tamponade. So mitral peak of E is over 25% changes. And then we can do tissue Doppler as well, but generally these three would be enough to diagnose the patient of constrictive pericarditis. On X-ray, if it happens for a long time, we can see that there's some calcification over the pericardium at the arrows pointing. We'll go through all of these. So these are the sensitivity and specificity of these of these signs. So if you find over 35% respiratory variation of peak diastolic MV inflow velocity, then it's quite sensitive to pick up that this patient has constrictive pericarditis, or if there's an hepatic vein diastolic flow reversal. Septal bouncing is easier to find, but it's not as sensitive or specific to the patient. And again, thickening is not very sensitive at all because anything can cause it, right? The other thing that we can find in these cases is called annulus reversus, where medial E prime is, I'll come back to this slide, and it should be more understandable when you see it in real life. And then annulus paradoxus. So we'll look at the picture first. So this is a 4-chamber view of the patient with pericarditis. As you can see right away, there's a little bit of fluid here, but outside here is pericardium. It's very thickened. You can see it's very white and quite thick, nearly a centimeter thick. And if you look carefully between the septum between the RV and the LV, you can see that it's moving, bouncing between them. And that is called septal bouncing. That's a subtle bounce between them. And if you do a subxiphoid view, you can see that the pericardium is really thick. It's as thick as the RV wall here. And it looks like it's touching the RV as well as not letting the RV expand out. The RV is pushing inwards rather than going outward, right? And again, we do Doppler inflow of mitral valve, PW on top of the mitral valve, and we measure E and A, right? So we look at E velocity first, which is 72 in this case. And then we do TDI, which is tissue Doppler. I hope you learned this in the other lecture already, otherwise it will get complicated and confusing. So when we do, I'm not covering the tissue Doppler in this lecture, it's the other teacher. You can ask them if you don't understand what tissue Doppler is. But tissue Doppler just measure the movement of the velocity of the movement of the whatever point we're looking at. In this case, we're looking at the mitral annulus. So we look at the medial E prime here, which is 10.2. Whereas the lateral annulus of the mitral valve is 6.9. Listen to this carefully. So normally, in a normal heart, the lateral free wall of the heart can move more than the medial side. Logically, if you think of it, because the free wall is outside of the heart, right? It can move more freely, whereas the medial side is stuck inside the heart, so it cannot move as good. So in a normal person, lateral E prime should be higher than the medial E prime. Whereas in constricted pericarditis, the lateral E prime is less than the medial E prime. So 10 and 6, right? This is why it's called annulus paradoxus. It's a paradox because it shouldn't be like this. The lateral should be higher than medial. And this happened in constricted pericarditis because the pericardium is so thickened and is pretty much attached to the free wall of the heart. So the lateral wall cannot move as good as before. Therefore, it's less than the medial side. So that's annulus paradoxus. And the criteria that I mentioned, mitral inflow variation of over 35, again, we do it like that. We measure the E during expiration and inspiration. So that one is about 70 and this one is about 50. So the inflow variation is over 35%. We can make diagnosis based on that as well. Or we can do it on tricuspid as well. You can see it changes. And then we can do a PW to the hepatic vein. And you can see that there's reversal during expiration phase. So it's normally it should just be the same height here, but when there's expiration, in this case, it goes all the way up here. So that's hepatic vein flow reversal. And this happens because the pressure inside the heart is so high that it pushes the, the, the blood back into the hepatic veins. And the other criteria that I mentioned earlier is annulus reversus. What did I just say just now? Sorry. Oh, sorry. Hang on. This lecture is the older version. So we're missing one slide. Sorry. So I'll explain this again. Sorry. When we do TDI of the annulus of the mitral valve, we need to look at the E velocity. Normally, in a normal heart, the velocity should be higher for the lateral side because it can move freely. But when there's a constrictive pericarditis, so the pericardium becomes thickened and it attaches to the free wall, the lateral side cannot move as much as the medial side. So there's a reverse there going on. And if we measure it with if we look at the velocity of the two sides, we can compare them. And normally the E prime shouldn't be very high, but because of the constriction, the E prime of the medial side is too high. Therefore, that's the paradoxus of it. Any question on that? I think I went as low as I could. Oh, okay. So once we have the diagnosis, we can, if there's a tamponade, we can remove the fluid, right? But if constrictive happen already, we need to remove the pericardium because it's preventing the heart from expanding. So we do pericardiectomy or surgical window on it. And it's a very difficult procedure because we have to, because the pericardium is just a thin layer, right? And it takes a lot of time to remove the whole thing. And it's quite difficult as well. This is the patient after removal of the pericardium. You can see that they can move, the heart can move better. It's the same patient. And now the IVC is collapsed just fine. And E velocity is much reduced from before. It was 70 something and now it's 48, right? And the TDI changes back to normal. So now lateral is now 9.7 and medial is 5, like how it should be. If you do it on a normal person, this is what it looks like. The lateral E prime velocity is higher than the medial E prime. And the medial E prime is less than 8, meaning that there's no paradoxus going on anymore. So that's it for the first lecture. It's probably the most complicated one of the day because there's so many diagnostic criteria. But generally, this is what would diagnose the constrictive pericarditis. This shot and the TDI shot. Do you want to take a break first, or shall we continue?
อาจารย์ครับ
Yeah.
Can you please explain hepatic vein flow in constrictive pericarditis once again?
Yeah. So hepatic vein for everyone, right? It drains into the inferior vena cava, which then drain into the right atrium and the right ventricle. So that's what the normal anatomy is. And it should be one way. So IVC should keep draining into the right atrium and right ventricle, and then it goes into the left side of the heart and it pumps to the rest of the body. But when there's constrictive pericarditis, the heart cannot expand, so the pressure builds up inside the right side and left side of the heart. So the flow from the IVC cannot enter the heart very well. So now when there's an increased pressure inside the right side of the heart, the pressure is much higher than it should be, so it pushes the blood back down from the right atrium into the IVC, and then from the IVC back into the hepatic vein. So that's why it's called the reversal of the hepatic vein. Where was that slide? Does that explain it to you?
Yes, Ajahn, I think it's quite clear now.
Yeah, okay.
I have another question. If we remove the pericardium in constrictive pericarditis, so is it gonna affect the hemodynamic of the heart, like physiology of the heart?
Yeah. What was the first part of the question? Sorry.
Like in constrictive pericarditis, basically we remove the pericardium, right? The thickened pericardium. So after removal, is it gonna affect the hemodynamic of the heart, like cardiac output?
It becomes normal again. So that's what I showed you just now. So IVC becomes normal size because now the pressure can distribute normally inside the right and left heart. And then we do inflow and outflow and TDI, and look, it becomes normal, back to normal. In this case, just now it was reverse, right? It's 10 and something just now. Now it's 10 and 5. It reversed back to normal.
In case we remove a large part of the pericardium, right? Imagine that the thickened pericardium is about like almost a larger portion. So in that case, the intrathoracic pressure gonna affect the.
All right, so that's what you mean. Yeah. So we normally don't remove 100% of the pericardium. It's not possible to do that, and also super difficult to do. We will try to remove the surgeon will decide which part is the thickest one, and it's usually the one that attached to the RV. So we'll remove part of it. And what you're asking, I guess you're asking if it can cause, side effect by removing it, right? It generally has more benefits than harm to remove it in the case of constrictive pericarditis. So the pressure changes, it needs to be done by using pressure wire, doing the coronary angiography or right heart catheter to measure the inside of the heart. But it will not be normal after the removal of pericardium, but it will not be pathological enough to cause problem. No.
Thank you, Ajahn, for the explanation.
This one I just added. There was going to be another number here, but it does to show that we're just moving it up, and we're measuring how the distance is traveling and the velocity is traveling, and then we can plot it into the graph, and we average it out into the number that we have just now. That's it really. So take a break or not? No? Okay, fine. It'll be another hour though. Okay, then we'll go on to the next one. So the next one will be cardiac mass and endocarditis. This one is more pictorial, so less intensive. We'll cover the one that the most problematic one first. So infective endocarditis, very common in Thailand for some reason, maybe because we have more virulent bacteria in our country than abroad. So in everybody's blood right now, there's some bacteria going on, but it doesn't cause problem because we can destroy it using our own immune system. And because we don't have a damaged area for the bacteria to grow. For bacteria to cause infective endocarditis, there must be a problematic area for it to attach. So like, let's say if the heart valve is damaged from other things, or if there's an abnormal blood flow causing the endothelium to be damaged, the bacteria inside the heart inside the bloodstream can congregate there and started to grow on top of it, and eventually becomes disseminated elsewhere. And normally, when you brush your teeth or you have your dental procedure done, the gum has lots of capillary supply there. And no matter what you do when you brush your teeth, you're gonna damage your gum. And as you know, the mouth is the dirtiest area in the body, right? The bacteria will enter the bloodstream. So as you can see, if you don't go see your dentist, you can have problem as well. So try not to have bad teeth or something like that, because that bacteria can enter your bloodstream quite easily there. And once it happens, and if it can cause infective endocarditis, the most of the symptom will come from fever and heart murmur. Heart murmur, as I told you many lectures ago, is when there's abnormal blood flow through the valve, causing extra heart sound. So to make a diagnosis of infective endocarditis, it needs a few things. You don't have to memorize the criteria for it, but you need to know what to look for and what are the signs for it. For medical side of things, we look at quite a few things. So we divide it into definite, possible, and rejected, and I'll show you that next. So for major criteria, for this lecture, it will be imaging, the echo side of things. For the medical side, we need to do blood cultures. If there's positive blood cultures for bacteria growing in the blood of typical one like streptococcus, then that's the major criteria, positive. Other than that, the minor criteria are the clinical sign that we can find. And this occur due to the dissemination of bacteria from the heart valve. So it can be things like fever or immuno changes like ocular or rust spots or vascular changes. And if the fever gone away within 4 days after antibiotics, then most likely it's not infective endocarditis because it's not that easily treated. I'll go back to that first one again. So if the heart valve, everyone here I hope has a normal heart valve, and I guess you all should have one. So even if you brush your teeth or if you have septicemia, which is ติดเชื้อในกระแสเลือด from whatever infection, you won't have infective endocarditis because the blood flow will keep going just fine. But if you have problem in the heart valve, like a damaged endothelial, these bacteria will come on top of it and start to grow there and then disseminate it. Once it disseminated, it can cause other signs like Janeway lesion and osler node. And these are what it looks like on the patient. So Janeway lesion is the non-tender red macular area on the palm and the sole. So that's what Janeway looks like. And then splinter hemorrhages are the linear streaks in the nail beds. Looks like that. And if it goes to the eye, it can cause subconjunctival hemorrhage as well, which is the red spot in the area here. And for immunologic reaction, so bacteria can, once it dislodge into the finger, it causes the body to attack it, and that's the osler node. So it's tender now, so it's painful to touch. And it can get into the retina, causing rot spot as well. So it's very problematic because it can spread everywhere in the body. So because we're doing the echoes here, so we need to know what to look for. So positive criteria for IE on echo is vegetation. Vegetation is bacterial growth on the valve. Abscess is the complication of bacterial growth. So if it start to digest into the heart valve or into the heart muscles, it can cause abscess or aneurysm. And then eventually the valve can perforate. Or if it's done on prosthetic valve, the valve can dehiscent and start to become loosened. Vegetation I will show you next. Abscess is more rare, but I think I have the picture here as well. But generally, because abscess is pus, so it's gnong within the muscle, right? So because it's pus is water, it will look like a dark area where it shouldn't be like this. And then sometimes it's not perforated yet, so there'll be aneurysm there. The wall becomes weakened. It can becomes a thin wall up there. And eventually it perforate and cause the blood to flow through it. Valve aneurysm is super rare, so I don't have an example, but the picture here shows the mitral valve and then it becomes aneurysmal change there. And yeah, if it's the bacteria can become attached to anything that's foreign body to the body. So if it's prosthetic valve from previous surgery, it can attach itself there as well and cause the valve to become dehiscent or become loose. Then this is an emergency and the patient needs to go back to the OR to have it fixed. Okay, so do you want to guess where the problem is on this echo? One volunteer.
Aortic valve is looking thickened.
Yes, that's correct. It's right here. It should be very thin, right? But you can see in some shot it's a bit thick and basically like a mass stuck there. Very good. So then we put a Doppler flow in. You can see that it has at least a moderate to severe level of aortic valve regurgitation going on here. For infective endocarditis, you may think that because there's a mass there, it might block the blood flow, but more commonly because it's on the valve, it destroys the valve. So it usually causes regurgitation no matter where it goes. So it could be mitral regurgitation or aortic regurgitation or tricuspid regurgitation, more so than stenosis. And we zoom in. Now we can see the mass clearer, slightly clearer. Is this bit here, sorry. is this one here, where it shouldn't be. So now this is a short axis view, right? And we zoom in onto the aortic valve. It should be a triangular shape and it should be thin. But again, we can see that there's a lump here. And it can be difficult to identify sometimes, whether it's calcification in a normal elderly person or like a vegetation from infective endocarditis. So sometimes we have to look at it in quite a few views. Okay, this is another case now. Where do you think the problem is? This one is easier.
Is it in mitral valve?
Yeah, it's right here. So as the heart moves, there's something going in and out of the field. That's a vegetation, very big one. Right there. You see? It's huge. And it's attached to the mitral valve because it's moving with the mitral valve. So of course it's gonna cause severe mitral regurgitation. Without even turning on Doppler, you can just guess. And also aortic regurgitation as well. So when this happens, you need to go back now to look whether there's, because the blood goes everywhere, right? Bacteria can go everywhere. So it can affect both mitral and aortic valve. But in this view, we can't see very much. But later on, we need to go look at it carefully. There could be an IE here as well, because it's thickened, the aortic valve slightly thickened, and the the other leaflet doesn't look very well, and it's causing mitral valve regurgitation. So it could be an old IE here, or it's, the vegetation could have been dislodged elsewhere already. We can't rule out it just from TTE. So sometimes we need to do a transesophageal echo as well. This is still the same case, and now it's a full chamber view. You can still see a little mass here. So now that you know how to identify the mass, we need to know how to identify the complication as well, because not everyone will show up to the doctors right away, right? Complications tend to happen when they leave it for too long. So other than the mass that travel elsewhere, like causing Jane spot and Osler and Ross spot, it can cause abscess and pseudoaneurysm and stuff that I mentioned. It can also travel to, what is this bit here? This pulmonary artery. If you look at pulmonary artery, there's something moving here which shouldn't be there, right? So that's another IE mass there. Probably traveling from the right side into the, from the RV into the pulmonary artery. These are all different cases now. And sometimes if there's a abnormal flow within the LV, the aortic, so the vegetation can attach itself there. And in this patient, if you notice here, he also has prosthetic valve, the mitral valve. Makes him more prone to have infective endocarditis. And when you zoom in, you can see things moving here. So we can do repeat echoes if you can't see on the first go. When the mass is large enough, it's usually easily identifiable. And on this is from the surgery, it will look like that. So bacteria will grow there, endothelium will try to cover it, and then it keeps going bigger and bigger. And this is in a prosthetic valve, so the bacteria will grow on top of it. It looks like that. We need to remove the whole thing and put a new one in. This one I put in because we're doing mass. So there is a thing called lamp excrescence, which can mimic infective endocarditis, but this one is usually a normal variation in a person. So some of you may have it. It's just a congenital thing and an extra extra structure, fibrous structure next to the aortic valve, and it can be a normal finding. So you have to look. That's why we have criteria to diagnose infective endocarditis. You can't just see a mass or something attached to the valve and say they have AE. You need to have other criteria like fever as well. So for lamp excrescence, these patients won't have any fever, right? Because it's a normal variation. For management of the IE, they need to have antibiotics for at least 1 to 2 weeks, and then they go on to have surgery to remove it, especially if there's severe symptoms like heart failure or if complication occurs already. But if it's a small lesion, like less than 1 centimeter, and if it's on the right side where the pressure is not as high, then we can sometimes give antibiotics only. Next, we'll go on to cardiac mass. We already mentioned one called lamp excrescence, which is a normal structural change, congenital change, sorry. There are many types of mass, like thrombus, which is one of the more common one we find, or tumor, which is more severe. Or if it comes from elsewhere, like metastasis from other cancer in the body entering the heart, or simply because there may be an artifact from calcium elsewhere and it looks like a mass. And it can cause many symptoms from blocking the blood flow, causing stenosis or regurgitation, or it can invade into the myocardium, causing reduced LVEF or arrhythmia or tamponade, or it can embolize into the brain, causing a stroke, or if it's cancer, it can cause fever and weight loss as well. So cardiac tumor is divided into primary and secondary type. Primary is when it's grown from within the heart, and secondary is due to metastasis, meaning that it comes from elsewhere, like lung cancer or breast cancer, and then it spread into the heart. For primary tumor of the heart, the commonest one is myxoma, which is benign, so it doesn't actually eats the heart and kills you from there, but it can cause a lot of symptoms from blocking the flow. We'll focus on that in the next slide. The way to differentiate it from echo, so the way to diagnose it for sure is to remove it or get a tissue sample from it to look at the pathology of it. But from echo, we can look at the appearance of it and make a good judgment whether it's primary or secondary. For primary benign tumor, it's usually smooth and well-rounded, whereas metastasis is usually very disgusting and it can be huge and it can be irregular and invade into other areas as well. If it's on the right side, it's usually metastasis because, as I mentioned, IVC and SVC drained from the body into the right side of the heart. So if the cancer travel from anywhere inside the body, it will drain into the right side of the heart. And so that's why metastasis is more common in the right side of the heart. And again, if it's genetic syndrome, it's complicated. You don't have to know about it. So these are the distribution. So for the common one would be myxoma, and it's usually found on the left side. Whereas the metastasis one would be on the right side. Yeah, myxoma is common as one, 45%, and then fibroelastoma 15%, and then lipoma 10%. We'll cover most of them today. So myxoma, being the most common one, is usually well-rounded, and it will look a bit gelatinous. So it will look solid, but it will look like there's some fluid inside there as well. The size can be from very small, like less than 1 centimeter, all the way to like 15 centimeters. On echoes, we'll find that echogenic mass is smooth and it usually attached to interatrial septum and may have a stalk attached to it as well. The problem is when it's big enough, it can protrude into the left ventricle through the mitral valve, causing mitral valve problem and causing symptoms like mitral stenosis. I don't even have to ask, right? Because you can see, you can all see the huge mass in the left atrium here. You can see that it's protruding into the LV and blocking the flow from left atrium into the LV. And the mass itself look a little bit, so it looks solid, but it also has some like dark area in between. So the dark area would be fluid, right? So it looks like solid and liquid inside there, which is why we call it gelatinous mass. And if you look carefully, sometimes there's a blood vessel supplying the mass as well. And it's blocking the flow completely. It's the same patient, but this time we do a short axis. You can kind of see the blood vessels supplying the mass, and it's attached to the interatrial septum. So that's the RA. This is the LA. So it's attached to the interatrial septum. Same patient. So left atrium, right atrium is attached to the interatrial septum and protruding into the left ventricle. And it looks gelatinous as well. And it's very well rounded, right? Still the same patient. So now we can see the blood vessel as well inside it, supplying, that's the circular thing here, supplying the mass. This is another patient, but this time it's on the right side. But no, sorry. If you pause it, you can see that it's blocking the flow completely. So not much blood is gonna get into the LV. Sorry, this is the Mayo view of echo as well. So the left ventricle is right here. It's from Sirilat archive. So they do a different view from us. The next commonest one is of the tumor is called papillary fibroelastoma. And it's usually found in elderly person, so 60-year-old and above. Again, because it's benign, so it's usually smooth and round. And this time it's described as front-like. Front is kind of like finger. So it looks a bit like a round finger. It's usually attached to the valve, 80% of them, and it's usually on the left side, aortic valve, more so than the mitral valve. This time, because it's on the aortic valve, it can travel easily into the brain because the aorta divided up into the carotid and it supply the brain. The patient can have stroke, MI, or syncope, or sudden death if it's too large. So it's, as you can see here, it's attached to the aortic valve. So for this case, why is it not infective endocarditis, even though it's a mass, right? And the answer for that is because we have to look at the patient as well. If they don't meet the criteria for IE, then it's just a mass. So this patient didn't have any fever and didn't have any sign of infective endocarditis. So it's just an aortic mass. I think there's right there. And it's the same patient? No, hang on. Not the same patient, sorry. This is a TEE, so it's transesophageal echo, because we can't see very well. We need to do a transesophageal echo. And as you can see here, it's right here. That's the LV and that's the aortic valve. That's mitral. So if you freeze the frame, it will look very rounded. And once you remove it, this is why it's called front-like, because it doesn't even look like something that would grow in human, right? So those are the benign one. This is now metastatic one. Before that, sometimes we do it Mayo style. So the LV is on this side and this is the RV. We can identify by the chamber size and the valve insertion. I think this was from Sirirat as well. That's why they do a Mayo view. So you can see here in the RA, that's a whole mass here, stuck and not even moving. So it's not mobile, it's stuck in the RA and it's very solid. If you put in Doppler flow in, you can see that the flow is hardly getting through into the LV, sorry, the ARV. And it's a huge mass, solid tumor. And now we do subxiphoid view. You can see that the mass originates from superior vena cava, probably from the liver or something, I'm not too sure. But because the cancerous cell entered the heart from the right side, it's attached it to the wall of the heart and it starts to grow bigger and bigger and blocking the whole of RA, as well as compressing into the LV, into the LA as well. And sometimes it can invade into the pericardium. So this patient has lung cancer, and then the lung cancer invade into the pericardium and pushes into the heart. This is a bit different from the other one where the mass was inside, right? This one is pushes from outside into the heart. Same patient. You can see that it's pushed from the outside into the heart. And again, because commonest mass in the heart is thrombus and metastasis cancer, so I have lots of picture from there. This one mass here is attached in the RV already. And another case, so the cancer is it spread to the lung and it push. So the RA is right here. So you can tell the mass is outside the heart, it's pushing into the heart, but it's not in the heart, just causing the heart problem from pushing in. So the next commonest one is thrombus, and it's usually due to many things. So the heart, normally the blood flow through the heart just fine. But if there's wall motion abnormalities, like as in after MI, or if there's aneurysmal changes, the blood can become stagnated in this chamber. Or if the EF is so reduced that the blood flows slowly, it can cause spontaneous echo contrast, and then eventually become a thrombus formation and inside the ventricle. Or sometimes if there's a foreign body for the blood to coagulate on top, like pacemaker leads, it can also cause thrombus to form there. Other things that can help formation of thrombus is AF and other diseases that can cause clotting problem. Sometimes it's very hard to identify because it can be laminated, so it forms along the wall of the ventricle. So this is a spontaneous echo contrast. You can see like a smoke appearance in the ventricle, but these are all tiny thrombus forming inside there. Eventually, it will coagulate into one big thrombus. And as you can see here, the heart is not beating very well. This is the left atrial appendage, and you can see the clot in there already. Sometimes it can be difficult to identify. Same patient. So now we do full chamber view. We can see that the huge clot is forming here and it's expanding as well all the way down here. And eventually will probably spread elsewhere. And that's the mass that we see earlier. This one here. So as you can see, one view on echo is not enough because it could be a whole thrombus here that we don't see. We only see a little bit here. But once we do a full chamber view, we can see that the whole thing is clogged by thrombus, the whole apex. And then this bit here is about to be dislodged. The end. Any question? If not, then we'll continue that. I think I have another one with you on Thursday afternoon, right? Yes. Okay, I'll end it for today.